introduction of ECMO, what do we see? We see a lot of bleeding. Why? Because there is hemodilution, there is a dilutional coagulopathy, there is a contact factor pathway activation. There is, like, as we go on a prolonged cardiopulmonary bypass, there is nothing but generation of thrombin storm. So thrombin generation exceeds the normal limits. There is platelet activation, dysfunction, and thrombocytopenia. And this thrombocytopenia gives rise to an inflammatory response. And it is this inflammatory response which ultimately will give rise to a whole lot of problems happening at all the fronts, uh, leading to bleeding. So when you have something called an ECMO in place, all depends on the nature of the centrifugal pump or the roller pump that you put, the speed at which you are doing, and the oxygenator. So bleeding thrombotic complications are more in the previous or yesteryear's roller pumps. They are more with the speed is fast, they are more if the membrane oxygenator is not a PMPA oxygenator. This is what we are learning as we are going along. The ELSO registry report also says this. We've been talking about oxygenators, but in this lecture, why do the patients bleed is our main concern. So as opposed to normal situations where aim is to achieve a normal coagulation, the goals in ECMO is to manipulate the coagulation pathway. So in ECMO therapy, complete correction of coagulopathy could result in circuit clotting and malfunction, and consequently some degrees of anticoagulations are required for maintenance. The risk of hemolysis can be minimized if you have a larger cannula and lower flows. So it is the duty of the person putting in the cannulas to have large cannulas, low flow, low as possible to maintain adequate oxygenation, and still always try to have around 1 to 1.5 liters per minute to prevent any circuit thrombosis. We may need to insert one more access cannulas and give high flow, not partial but complete CPB also sometimes. And always remember, the moment you start to see even very small clots on the oxygenator, change the oxygenator as much as possible and as fast as possible. Monitor the decreasing hemoglobin, the increasing plasma-free hemoglobin, the increasing bilirubin, the urine color, and the renal function tests. And ECMO, remember, there is no endothelium. You're working on an artificial endothelium. So obviously, with an artificial endothelium in place, the absorption of proteins and platelets will be like a consumptive coagulopathy. They'll undergo more denaturation. There would be activation leading to consumption of all the factors, your tissue factor, factor 5, factor 7, factor 10, factor 11. All your precalciferin and your bradykinin complement pathways will also be activated. There will be fibrinolysis with plasminogen and complement activation as well due to the damaged endothelium, and there will be thrombin, heparin, platelet activating factor, and surface contact factors all coming into play, giving rise to bleeding with sepsis. Protein C and protein S, which are seen in plenty in sepsis patients, would be there on this patient. So when you see these things happening, you still continue heparin. Why? Because we need to anticoagulate during ECMO. What is the reason? Despite tremendous advances in ECMO circuit technology in recent years, we still are far from the situation where we can have an endothelium of the ECMO circuit, which is like the physiological endothelium, which releases nitric oxide. None of the endotheliums of the present day machines, even MECA, the CardioHealth, does not release nitric oxide. So we need a circuit which releases nitric oxide, which prevents too much of platelet aggregation. So proteins in blood accumulate in the circuit membranes, causing the risk for platelets and leukocytes aggregation to the membrane surfaces with complement activation and kallikrein activation. The heparin-coated membranes that we use are being utilized with many centers, so that there is no need to give only very little amount of ACT and of heparin, so that the ACT is on the lower side. Normal ACT, we say on ECMO, is 160 to 180 up to 250, but not beyond that. Today, we are thinking of ECMO and VADs being put in a ACT less than 80 or between 80 to 120. That's where we are moving with these heparin-coated circuits. And if you see experimental animal studies adding nitric oxide releasing polymers to the ECMO circuit, may improve the platelet activation, addition, and consumption process. And nitric oxide prevents platelet aggregation. That's what you should know today. And adding direct thrombin inhibitors such as bivalirudin or agatroban, you have in the COVID era anti-COVID thrombosis, adenamab, and I want to talk about these direct thrombin inhibitors in one of the next few ECMO classes. That's a separate class altogether when we talk of heparin and its alternatives. But lot many group 2b3 inhibitors are coming up in the market following COVID thrombosis. Resilius is one of them. These are those which not only release nitric oxide, but they do not cause that much of consumptive coagulopathy because they are direct thrombin inhibitors, and heparin acts through antithrombin 3. So platelets are the center of the coagulation universe. They are releasing, they provide the binding factors for clotting factors. They release additional clotting factors and assist in clot retraction, and platelet aggregation therefore becomes need of the hour. So the reason for the patient's bleeding is that your intrinsic pathway and extrinsic pathway, which meets at the common pathway to form activation of factor 10, is actually not a cascade. It is not a linear cascade, it's a phasic cycle or a phasic circle. One thing leads to the other. And when you have something in circle, a vicious property sets up, which gives a negative feedback instead of a positive feedback, and does not go in a linear manner, but goes in a round the clock manner. So surgical factors like ECMO circuitry is very, very bloody. Why? Because there are big pipes, big holes, and big vessels. And always remember that between the two types, the veno-arterial ECMO bleeds more than the veno-venous ECMO. So platelet addition, aggregation, and activation lead to a clot firmness. And this is what I want you to remember, that there is in ECMO generation of thrombin, there is clot firmness, and what happens to the platelet response is our duration of the ECMO circuitry that we use. So although the ECMO circuit has an anticoagulant lining, a low dose heparin is usually administered to prevent clot formation. ECT is normally titrated to maintain a heparin infusion rate in the first 24 hours and measured 6 hourly on the first day. It is performed by the attending nurse using 2 mLs of arterial or venous blood. A usual target for ACT in a non-bleeding patient with a platelet count more than 80,000 is between 140 to 160. This could be an MCQ and you should know this. Today, with clinical conditions like post-surgical bleeding, sepsis, hypothermia, and hemodilution, there is constant transfusion of blood products, continuous heparin infusion, neonate, infant, immature coagulation systems, low antithrombin 3 levels. The pharmacokinetics and heparin are different with neonates versus the adults. The sulfated glycoproteins, which are naturally occurring, are extracted from the lung, intestines, and pigs and cows with no direct anticoagulant effect. The mechanism of action is always to stimulate the antithrombin 3 activity 1000-fold. So these are some of the principal effects that you must know. The partial thromboplastic time, the desired effect level is 1.5 to 2.5 times the normal. The ACT on ECMO desired therapeutic level is 160 to 200 in some books, but 140 to 160, 160 to 200, not beyond 220 or 250 is the amount. Anti-10A factors, because 10A is the common cascade, therapeutic levels 0.3 to 0.7, bleeding, osteopenia, fractures, and stimulation of antibody production leading to HIT and anaphylaxis is what happens on ECMO, and we must be all very prepared. So heparin resistance, heparin-induced thrombocytopenia with the use of heparin are very, very common. And if you have heparin resistance, then you will require heparin twice the normal dose, that is more than 3,500 units per liter per day. And the etiologies are the formation of the antithrombin 3 level or activity. This stat order should be to give antithrombin 3 levels for measurement every 4 hourly if you have heparin resistance, and replace it with factor fresh frozen plasma. And you also look out for acute phase protein factor 8 elevation. Beyond 24 hours, the APTT performed in the hematology lab is primarily used to guide heparin therapy. It can be performed 4 times a day, but it is very difficult to do an APTT even once a day. Most of us would realize this who work in the ICU, and therefore APTT once a day should be done when you are on a heparin therapy. And this should be maintained, and that is the take home message here. A very important MCQ coming to most of you in your vivas also. The APTT normally on ECMO with more than 80,000 platelet count is how much? It is between 50 to 90, but even if you say 45 to 55 seconds, it's fine. Normal is 50 to 90, but on ECMO, try to maintain it less than 55. So do a daily X-ray test, do a urea, creatinine, all the electrolytes like calcium, sodium, potassium, magnesium is important, phosphates, and liver function tests. APTT, INR, and serum fibrinogen you should perform as much as possible. APTT in the first 1 or 2 days should be done at least 6 hourly, 3 to 4 times a day. But we are not doing APTT more than once a day, and we resort to maintaining platelet counts and PT-INR in 1.5 to 2.5 times the normal range, and also try to maintain a platelet count above 80,000 all the time. Also remember the plasma-free hemoglobin is a very important indicator of hemolysis. The safe ranges less than zero point 0.1 gram per liter. Levels above this must be discussed with ICU consultants and the perfusionists. Daily D-dimers can be performed while on ECMO if your patient has had COVID with ECMO or is having any viral myocarditis or a viral pathology. It is safer and better to do D-dimers with the fibrinogen levels. Today, we may not be doing it on a routine basis. If you have a TEG or a sonoclot, we'll discuss this, but blood cultures should be done at least once or twice a week if the patient develops fever, and other cultures like urine culture, etc., can be done depending on the conditions of the patient on which for which ECMO has been put. Remember, while you're on ECMO with heparin, look out for, even without heparin, always look out for DIC. Disseminated intravascular coagulation is very common, as I said, because of consumptive coagulopathy, and coagulation is usually confined to a localized area by the combination of blood flow and circulating inhibitors of coagulation, especially antithrombin 3. If the stimulus to coagulation is too great, these control mechanisms can be overwhelmed, leading to the syndrome of DIC. So, DIC is, though not a primary disease, but a disorder secondary to numerous triggering effects, such as serial illnesses for which the ECMO was put. And therefore, a surge response happens, and this surge response leads to release or exposure of procoagulant material into the bloodstream, maybe a postpartum hemorrhage due to obstetric reasons, or maybe a cancer patient. A patient may develop a thrombus, cancer, or maybe a trauma patient on whom we put an ECMO. So these are patients where you must know that necrotizing pancreatitis, major trauma, both pathways of DIC as well as of consumptive coagulopathy become activated with the platelets. So important to keep seeing your cannulas on X-rays. So routine X-rays are a must. Important that we keep reading and writing the latest on heparin, the latest on anticoagulants being used in ECMO. You'll see some of the latest literature coming up on bivalirudine use and agatroban use in ECMO, or just doing ECMO with heparin-coated circuits. That is where we are today in 2020. But if you see the BEMBI studies where they have said what is the anticoagulation modalities for pediatric ECMO, then the age differences as well as the variability over days of coagulation monitoring on ECMO is said, and they laid a lot of emphasis on getting routine anti-10A levels as well as antithrombin levels with the ACT if heparin is being given. And many new such studies are coming up. I will be sending you recommended reading for these studies. You must know your anticoagulant very well. The pharmacology of the anticoagulant, whether it is heparin or antithrombin, whether it is agatroban or bivalirudine. Those are the three we are using, or everything about the heparin coated circuits should be known. Now, once you have a patient on ECMO, there are so many additional options to do beyond the conventional laboratory tests of platelet count, PT, INR, APTT, and your anti-10A, as well as your fibrinogen and antithrombin levels. I do not say that you should not resort to these levels, But let's say you do fibrinogen twice a week if the ECMO is going stable. It depends on what the condition of the ECMO is, and the frequency of your test would be dependent on that. But always buy an ECMO machine at your center with a point of care blood clotting machine. It could be a simple one like Sonoclot. It could be a very, very heavy one like Rotum. It could be a TEG, whatever you decide to use on. Remember to put these on. Additional options would be Sonoclot, platelet function testing, specific factor assays, fibrin degradation products, Rotum, TEG, and multiplate, etc. Any one of them can be used. So, problem in blood transfusion is you are wanting too much of blood being given on ECMO, and patients don't want it because there are financial consequences. There is a lung injury with excessive uh, transfusion, demand versus supply, and financial consequences and hazards of more transfusion leads to more mortality. So algorithms should be set in place. At AIMS, we had an algorithm when we set out to do ECMO on our cardiac surgical patients. This went back as early as 2017 when we were using TEG and Sonoclot and Rotum. Now, I want you to know that anytime you have an ACT which is more than 130, yes or no, if it is and it is being more, then you can give protamine. If you are weaning off ECMO. But if you have ACT which is much, much higher, then you go on, take your blood in a Rotum sensor or in a Sonoclot small cuvette, which works on a viscoelastic measure, and see the CT extem on the Rotum. We'll come to that and have a separate class on this maybe next time. But I wanted to sensitize you that point of care testing machines are on, and CT heptum with CT extem, there are 4 channels on the rotor machine. These 4 channels are called the extem, the intem, the heptum, and the fiptem. Now, each of these channels tests the extrinsic pathway, the extem, the intrinsic pathway, the intem, the heparin pathway, the heptem, and the fibrinogen pathway, the fiptem. When you have these pathways, then you see the levels. We will do these levels. So you have the levels called clotting time extem. There are values of this at the bottom of the signature curve that comes when you put the blood in this viscoelastic machine, which works on the principle of viscoelastic measures, wherein there is a magnetic field created in which a small pin from the magnetic machine, from the machine, moves onto the patient's blood in the cuvette. And what is lined in the cuvette is an indicator. It could be a tissue factor for extem, it could be a heparinase for heptem, it could be a acid for, uh, you call it allergic acid for fiptum, but different indicators are put on the vials, small vials in which you take zero point 0.4 ml of the patient's blood. This pin moving onto the patient's blood creates a signature. The signature moves with alpha angle, R time, CT time, MA, lysis. These are 5, 6 factors which are there. So you make your algorithms in your center and see these values. This is another learning, and it is a very deep learning. But I want you to know that CT extem, if it is more than 80, and a CT heptem, if it is more than 240, then definitely this patient of yours is going to bleed. So this within 10 minutes of starting the signature is a good marker that your patient on a rotum machine or a sonoclot machine is going to give you a signature, which will tell you whether ECMO is going to lead to bleeding or not. So that would be a marker, a prognostic marker for you to decrease your heparin or switch from heparin, wean it off completely, and switch to a heparin bonded circuits, or we are not still on low molecular weight heparin, or quietly start adding a bivalirudine or argatroban. But you can't just switch off heparin completely. You would try to come off ECMO first, wean off complete heparin with protamine, and then give argatroban. That's another call, but those calls and those options are coming up. But right now, we'll focus on R-A10 and C10. So the very fact that A10 signifies 10 minutes, in 10 minutes, if your A10 on XTEM is less than 40, the amplitude, and A10 on FIPTEM is also less than 7, this patient is going to bleed. This is a patient who's going into hypofibrinogenemia. So your factor fibrinogen, which is an important clotting factor, is going to decrease. And decreased fibrinogen is going to cause AIC. So the moment fibrinogen decreases, you give a blood component therapy called cryoprecipitate and not whole blood. Whole blood does not contain fibrinogen so much, but cryoprecipitate contains fibrinogen. So I hope you do understand what I'm trying to say. These point of care testing tell you within 10 minutes whether your patient is going to be normal or bleeding. If it's going to be bleeding, three conditions may happen: either a decrease in fibrinogen, or a decrease in platelet, or a consumptive coagulopathy of DIC. We will go as we go by, but I wanted to stick you to this algorithm, that various algorithms are there in publications, at least 7, 8 of them, but stick to your institution algorithm on the kind of point of care machine that you are taking. With experience, it becomes in very handy. Any ongoing significant bleed, if it is there, and you have corrected with cryoprecipitate or with a single donor platelet, if your platelet was less and your values are coming to near normal, do not forget the normal, that is the temperature. Patient may be hypothermic. There is hemodilution because you're on an external surface. There is hemodilution, there is hypothermia. So correct the temperature, warm the patient, correct the acidosis, see that the pH comes up, the basic cells becomes normal, see that the lactic acidosis disappears, your gases are right, correct all that, give bicarb, maintain the FiO2 more than 50%. And once your PO2, your basic cells, your pH, lactates are all done, your electrolytes are all, dyselectrolemia is corrected, you will see your patient doing very well. So these point of care tests, like your ABG machine, are very much there to tell you about a hyperfibrinolysis due to decrease in platelets or thrombocytopenia, a hypofibrinogenemia, or a DIC. So that's where I am, and I would go fast now. Point of care testing for coagulation can provide specific, reliable, timely information about bleeding episodes, and the use of targeted therapy algorithms could improve outcomes and reduce costs. So this is your single chamber ACT machine, which gives you an ACT value, which gives you a printout at you, as you can see. It gets connected to a laptop, which has all the software connected. And you can see this is the chamber for the where the cuvette is put, and this is the screen on which the measure comes. This is costing very little. It costs just 6 lakhs rupees, and it's the prices are coming down in single chamber. A double chamber costs more, but heparin effects with a prolonged CT time. This is the signature which is before heparin. When you give heparin, it becomes straight. There is no mark coming. So we tend to add an indicator which overcomes the effect of heparin, and that is heparinase. So it shows slow fibrinogen to fibrin reaction if heparin is there. And this normal peak that you see is a measure of your clotting time. What are we doing in these point of care tests? We are measuring the clot formation, MCF on ROTEM, and peak gradient here, the CR on clot retraction and clot formation on sonoclot are your peak. Once the peak is there, this is your dissolution of the clot. The platelets aggregate and then fibrinolyze. So this is normal fibrinolysis. But when you have a condition like this, here the fibrinogen quickly moves back into a liquid. So you have hyperfibrinolysis here. There's no peak. The clot formation is very little. So confirmation of hyperfibrinolysis interpretation is simple. When the sample is discarded, observe if the sample is liquid or not. So let's see an example of ECMO. A 22-year-old patient undergoes a TOF and is put on ECMO for low cardiac output. His baseline hemoglobin read as 26.5. He was hypercyanotic with a hematocrit more than 65. When on CPB, 1100 ml was taken out of circulation. This was a part and parcel of our MUF that we do, or a conventional ultrafiltration that we do to concentrate the hemoglobin and give the right hemoglobin so that the blood product usage post bypass is less. Post protamine, this patient was very oozy. He's a cyanotic patient and the cardiac output was low. So he was put on ECMO. Now on ECMO, we did a sonoclot analysis, which shows a dilutional, acute dilutional coagulopathy. You see what is happening here. Post-protamine on day 1, the pH is less, 7.25. On day 2, it becomes 7.02. And after infusion of platelet concentrates on an FFP on day 3, it becomes 7.3. And day 4, it becomes normal. Likewise, on day 2 and day 3 after FFP, even the PO2 is less. The basic cess is shifting. It becomes normal on day 4. But what is very significant is your lactate is high and it becomes near normal. So when you have something like this and you put the patient on ECMO, you can see the gases becoming better, the temperature stabilizing. Even if there is a dip on day 2 and day 3 after putting on ECMO, if you maintain the blood bath temperature, the bath temperature that we put in with the ECMO, 237, your body temperature would come around 35, 36.5. The tachycardia would settle down, the CVP would become normal, and your saturations would be above 95, 98%. So this is the acute dilutional coagulopathy. You did not see a peak. There is no clot formation happening here. Your clot rate is high. It is 6.1. It is not happening. And your platelet function, which comes down on the peak, is low. It is 0.3. So clearly, this is a hyperfibrinol, this is a dilutional coagulopathy with thrombocytopenia. So your patient needs platelets and your patient needs also fresh frozen plasma, but not cryoprecipitates. So he was wheeled out, continued to bleed till 12:30 in the night. The chest tube output was 3100 ml, not taken for re-exploration based on sonoclot because we had given to this patient a lot of platelet concentrates and FFP, and the test drainage output became better. And within an hour, the patient with 15 units of platelets and some of cryo became better at 1:30 in the night. And when we performed the repeat sonoclot analysis, you can see the clot formation became better, the clot retraction was better, and so was the peak and the platelet function. It came from zero point 0.3 to 1.9. So that is the beauty of a simple machine called sonoclot, where your clot retraction, which was low 6.3, becomes 18, your ACT becomes 145 near normal, and your patient does better. Again, another example of a 5-year-old girl undergoing a Fontan surgery had a platelet dysfunction in the baseline. The baseline plate prothrombin time was 12 seconds, HB was 9.6, and the platelet count was normal, 1.15 lakhs. This was the platelet dysfunction with a platelet function of only 0.9. There's no peak and there's no dissolution down. So correlation is found in our ROTEM studies between prothrombin time and A10 of extem, between APTT and CT intim, between fibrinogen and A10 of fiptem, and extem A10 and MCF extem final obtained, which suggests that accurate information on clot firmness could be obtained within 8 or 10 minutes of the values. A lot of studies done by other people also show that intraoperative infusion of noradrenaline when the patient is on ECMO improves the platelet aggregation in patients who are undergoing CABG and are put on ECMO. Thrombin generation is something that I talked about on a ROTEM. If you see CT extem, as I told earlier, more than 80 seconds, and at 5 minutes, the fiptem is more than 9, then it means your clotting time here is not right. So this patient needs either a fresh frozen plasma, 10 to 15 ml per kg, or a point of the platelet concentrates, 15 to 25 units per kg. If it is normal and everything is fine, you see these graphs. This is now from sonoclot, a TEG or a ROTEM graph. This is for ROTEM. We will talk of TEG also. TEG also is and ROTEM are basically the same. The machines are different, the software is different, and therefore your screen outputs are different, but the graph reads the same. So that's your simple CT time. That's your alpha angle. And that's your extem, fiptem here. That is the fiptem, that is the extem, that's the extem and fiptem again. And here is your intim. Remember, extem, fiptem act together, and your intim and aptem and act together along with heptum. So that is the extrinsic pathway. It shows near normal, 19 minutes here, CT time, 175 centimeters, 110 kg patient, shows a decrease in fiptum at A10, and this MCF is also decreased. So to this patient with extem being CT being high, you give 1500 units of PCC. Alternative is to give 6 units of FFP, but you give both and you see the correction. Now, Annabel Blasi said that thromboelastometry reliability for detecting safe uh, coagulation thresholds for patients who are on warfarin after elective cardiac valve surgeries should also have an extem CT more than 84 seconds. And if it is more than 84 seconds, it predicts an INR value of more than 1.5 in nearly 93% of cases. Now, this study from Journal of the Reputation of Thrombosis Research in 2015 paved the way for point of care testing to come up in a better way. If your patient is on a no side, then you keep doing your CT heptum and intim and find them also increase, then you can think of a protamine overdose. And we may have given more protamine, and in this patient with protamine overdose will not require any platelets or cryo, but will require an FFP only, 10 to 15 ml per kg body weight. So this is a typical protamine overdose, and when your amplitudes are increasing, your CT is above the normal range, and you have your alpha angles increasing, that is the time that you can think of protamine overdose. But what happens when you have bleeding and a CT in intim more than 280 and a CT in heptum more than 280? You can also consider hemophilia in these patients. So there are very many graphs coming up. This is a study on itself. I invite you all to join the patient blood management course, which we just ended, teaching you everything about all this in details. But before you want to do this courses again and again, we'll be starting one in Jan end next year. You're all welcome to join it. You must know that ECMO cannot run without a point of care test today. It gives you very good results, and it tells you everything about outcome measures of ongoing bleeding and whether to continue with that much amount of heparin or that much amount of ECMO flows or not. So whether it is bleeding or it is thrombosis, remember you see the alpha angles, you see the CT, you see the clot firmness here. This is the MCF. So you see the MCF at A5, at A10, then it will normally start lysing. It comes as a tapering lysis. But if it lyses faster, it is hyperfibrinolysis, and that's also bad. And if you have a piptum where there is an increase in your MCF above 11 or above 15, it is 31 here. So definitely this is a patient who is having a lot of uh, thrombosis, and this patient of thrombosis is going to form clots. So you do a quick checkup, you see a quick INR 3.5, a PTT of 62, uh, 0.8 seconds, and you see a fibrinogen level of 6.56 grams. They're all on the high side. So what are they telling us? That this is not a bleeding patient because of fibrinolysis, but this is a bleeding patient because of thrombosis. So rotational thromboelastometry predicts thromboembolic complications after major non-cardiac surgery as well. And postoperative thromboembolic complications, though PT, PTT, INR or platelet count can tell us so much more, but it is the interim at A10 which is the best predictor of thromboembolic complications, with a ROC area under the curve of 0.75, and there was no significant difference for any fiptum. So relationship between transfusion of blood products and the incidence of thrombotic complication in neonates and infants undergoing cardiac surgery shows that increased incidence of thrombotic complications happens in most patients, and these patients require point of care testing for good patient outcome analysis. These are some analysis that we have done on our cyanotic patients, because most of these patients of TOF, of DORV, of patients who were even Al-Kappa patients, of TGA with intact ventricular septum having an ASO, or of truncus arteriosus, we were putting them for low cardiac output on ECMO. So that's where we decided to do integrated ECMO on these patients and put the cannulas of cardiac surgery cannulas by the surgeon of the ECMO cannulas, the return and the access cannulas. And we went on ECMO during the surgery, and so that post bypass, we were also on ECMO. So that is how we've saved so many patients. We've prevented hyperfibrinolysis. We've had no problem with heparin protamine management. We've seen clot firmness beautifully on sonoclot in the initial days between 2014 to 2017. And then from 2017 to 18, we used TEG. From 2018 till 2020, we've been on Rotem. We've been learning. The learning curve between ECMO and point of care testing has made us realize that 80% of patients of bleeding or thrombosis are salvageable on ECMO if you can monitor your heparin levels and titrate them with good point of care testing in the first 10 minutes. Prevent thrombin generation and do keep doing point of care reassessments, maybe twice or thrice a day. This simple test done more frequently in the earlier period would give us more results than the test done at a later period. So those are our experiences, some of them on an Excel chart for you. We are coming out with the paper very soon. We put 6 CABG patients on ECMO. We did platelet aggregometry values on ECMO with CABG patients. We've done this kind of platelet function analysis with not just extem, intem, fiptem, and heptem, but also with monitoring area under the curve. One of our patient residents is presenting platelet function analysis in CABG patients today in the evening in the VA News paper. Do listen to him, how and what we have done on our 26 patients. Our patients who are on CABG and go on ECMO in the post-op period are the patients whom we lose. Why? Because ECMO is put late. These patients are on a dual antiplatelet like aspirin, like clopid. So if you have a platelet function test like ADP-10, which blocks the activation of aspirin, or you have clopid with Aratem, which blocks the activation of the first was aspirin, the ADP, and Aratem for clopid, or you have Traptem, where the thrombin is blocked. So thrombin reactivating protein 10 is what it is called. So when you have these things blocked, then the area under the curve will be less than normal. So from a 53 area under the curve here or 55, you'll go up to values as low as 10 or 12. So when you see area under the curve coming down in the first 10 to 15 hours, anticoagulation is the culprit. So decrease your heparin doses to the minimal and see a lower ACT, and you'll see your patients do well. So that's what we are. We predicted this and wrote it as a review that ECMO patients, though we have serum fibrinogen, the ADP-TEM, the ARA-TEM, the TRAP-TEM, the ADP aggregometry is very good. And if you do biomarkers like metalloproteases with PA1 for sepsis or lysis at 60 minutes, then we can know from an early stage about the clot strength from extem and intem, about the fibrinogen activity from fiptem, about the fibrinolysis from extem and intem and fiptem. And ADP-TEM, ARA-TEM, and TRAP-TEM tells us in a detailed way how the ECMO patients are going to be bleeding or not bleeding and going into DIC or not going into DIC. What did we observe? Our major observations in ROTEM during ECMO is that CT of ectum is low in majority, approximately 50%, indicating likely factor deficiency. CT of intem is normal, indicating minimal contribution of heparin to coagulopathy, but MCF reflects the clot quality in normal range or high in majority. But when it is low, when MCF is low, it means it's hyperfibrinolysis. It is a predictor of low platelets. If it is low MCF in fibrinogen or FIPTEM, it is a predictor of hypofibrinogenemia. The ADP-induced tests are low in 72% of patients on ECMO of prolonged duration, and the TRAP-induced tests are low in 50% of patients beyond 5 days on ECMO. So is rotational thromboelastometry the answer for rapid prediction of coagulopathy on ECMO? Well, the answer is yes. ROTEM is an accurate and rapid tool for analysis of coagulation pathway. There is both qualitative and quantitative platelet dysfunction on ECMO that cannot be assessed by standard tests, and platelet aggregometry can come up to be a very valuable tool to assess the platelet dysfunction while on ECMO. This was the algorithm which we used for our ECMO patient. We did serum fibrinogens, we did ADP-TEM, ARA-TEM, and TRAP-TEM to tell us about the dual antiplatelet drugs that the patient was. Then we did a residual ADP aggregometry, and for sepsis, we did PA1, metalloproteolysis, and lysis at 60 minutes. And we followed this when we were weaning off with protamine and post-protamine even in our CABG patients. And when we did this, then 18 extem and MCF-fiptem, 18 extem with less than 40 and Piptim less than 7, these are the patients who are going to bleed. And if they bleed, then that is the amount of cryo, 10 milligram, 10, 1 unit per uh, milligram kg. And proton, when you give the platelets, it's also 1 unit per 10 kg. And FFP is also about 10 ml per kg. So CT XTEM is what we look at. A10 XTEM is what we look at. Piptim A10 is what we look at. And surgical hemostasis is always looked at all the time. So we see the areas and we see how the areas are working.